All right, we'll get going. Well, welcome everybody. Thanks for being on time and ready to go. You're here for the Module 11 Zoom session. Dr. Hurwitz tonight. I don't have any major announcements at all. Lisa, did you want to comment at all on the family visiting program? I know you've been working hard on that.
Yeah, so I'm just having to verify with one last parent because one backed out. So, and just matching up the last couple of trainees, it's kind of tough. I want to make sure I do all the right thing and match you up with the best families that may help you the best. But you should have this information tomorrow.
Oh, awesome. Cool. I didn't even know that. Thank you. That's great. Great. Thank you so much. So yeah, so
you know,
oh, of course. So all our trainees look for that either, tomorrow in the coming days here, you'll get more information on how that's going to work and what's going on. So with that, Dr. Hurwitz, I'm going to turn it over to you.
Excellent. All right. Well, welcome everybody. It's my pleasure to speak to you. I always enjoy giving this seminar. My name is Ed Hurwitz. I am a pediatric physiatrist, which means I'm a physician who does physical medicine and rehabilitation. I was trained as a pediatric specialist, so I do a lot of work with kids with developmental disabilities, and I have over the years become a specialist in working with adults who grew up with a pediatric disability. What I want to talk to you about tonight is a couple of things, and the first thing is implementation science and knowledge transfer. The point of this goes along with the curriculum that we've been talking about with evidence-based medicine. And the discussion is about how evidence-based medicine slowly makes its way into the clinic. Let's see. Okay, so let's start with a couple of definitions. Implementation science is the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings. In other words, studying why something goes from evidence, why and how something goes from evidence to practice. Knowledge translation is an important part of implementation science. It's a dynamic and iterative process that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health, provide more effective health services, and strengthen the healthcare system. This diagram gives a kind of an overview of how knowledge turns into practice. So you start off with innovation through basic science or other mechanistic research, animal science, and so forth. And then you move on to clinical trials with real people to establish the effectiveness. Once you've done the work to establish that a certain treatment is effective, it may be pertinent to compare it to other treatments for the same problem and decide, is this treatment the most effective treatment? Or is it better than the old treatments? And what's the exact best way to give this treatment, and develop guidelines that show that. So from there, you attempt to translate it into actual practice, and you run right into implementation barriers. We're going to talk about some of the things that need to happen to break through those implementation barriers, including knowledge transfer and cultural change, in order to translate that knowledge into practice. So let's talk about some of the barriers. So we divide them into categories. The first category is the clinician. So the clinician may have some barriers related to the clinician's knowledge. They may lack awareness. They might not even be knowledgeable about this kind of treatment. Or they may be knowledgeable about it, but they're not familiar enough with the treatment to actually start thinking about putting it into practice. On the other hand, even if they have the knowledge, there may be some attitude issues. For example, they may just not agree with the treatment. They may not have the self-efficacy to change and put new treatments into practice, and that may be due to a lack of skills. There may be some cognitive or physical skill that they lack in order to do that. There may be a lack of learning culture. So in other words, they may be caught in a practice mode where they're just grinding out the work, just doing the same thing over and over again with no real expectation or a culture that they change and learn new things. There may be a lack of outcome expectancy, which can mean two things. One thing, the clinician may assume that there's not going to be any change in outcome from this new treatment, or it may be that the clinician has no expectations in their work that they change outcomes. Their job is to apply interventions. What happens to after that is not their responsibility. That sounds very strange, but unfortunately some practices are that way. And there may be a total lack of motivation. Again, they may just be in there to just get through the patients and not be so interested in exactly what happens. So how do we address those clinician barriers? Well, the first thing is dissemination and education. We give new knowledge, and we do that nationally, and we do that locally. I should mention the pandemic has interfered with this greatly in terms of the fact that we just don't go to national conferences the way we used to. And that's going to be coming back. Hopefully, the plan is for they coming back in the next several months or so, but there's been quite a lack of education and moving things forward. I know there's been Zoom meetings, but they just don't have the same effect, especially for active learning, which is new skill acquisition. The ability to go to a conference and actually get practice in learning a new skill has been greatly impaired. And there's endorsement, having experts in the field say that this is the kind of treatment that should be done, and the larger community support. If everybody else is starting to do this treatment, this evidence-based treatment, it's hard to stay behind and say that I'm not going to do it. And then there's the issue of having a culture of change in your practice. So that comes from leadership. The leaders have to say, we want the best evidence-based practices when we're working with people in this practice. And that means changing expectations. Your expectation will be more tied to having greater, better outcomes from newer and more innovative and evidence-based treatments rather than just producing numbers coming through your clinic. And it also comes from disseminating outcomes, telling people that if they do these things, they will get better outcomes. Most of us really want to do a good job and have good outcomes, so that's a very powerful tool. Next are the guideline factors. When we take that evidence and we translate it into guidelines. Well, is there enough evidence really in the guidelines, or is it mostly just expert opinion, which is a form of evidence, but it's not the most powerful form of evidence? Are the guidelines plausible? Do they sound like they make sense? Do they fit in with the biology and the social structure and so forth? How complex are they? Are they too hard to follow? Are they laid out well so that you can follow them well? Do people have access to the guidelines? Are they able to find the guidelines in some obscure place where they can't be really read? Are they applicable? When a person who treats this population looks at them, are they going to say, this is applicable to my population? And one of the things that goes along with that is if there's a focus on patients with single disease entities, excluding complex patients. So for example, I treat a lot of cerebral palsy. If you were to talk about drooling and cerebral palsy and talk about treatments for it, are you taking in all the other factors that go into an individual's cerebral palsy to consider whether the treatment regimen you've just suggested, does it fit in with everything else in that person's life? These patients can be very complex. Sometimes there's a lack of clear intervention goals. You've given me a new guideline to look at something, but what's it for? What's the purpose? What's coming out of it? And is it trialable? In other words, is the guideline set up in such a way that I can, without a lot of difficulty, try it in my clinic and then make it better and better till it's working? Or does it all go in one shot? It has to be the whole thing brought in, and then from there I can see if it works or not, which is a much more difficult way to do it. So we can address these guideline strategies by having a strong evidence base, looking at the literature. Getting that expertise is part of the evidence base. And before I talked about endorsement of experts, that's part of it. And then reporting outcomes from people trialing the guideline can be very helpful in helping people accept the guideline. Making the guidelines simple and accessible. So for example, making it a checklist, that's easy enough. Using available technology. So for example, the electronic medical records have these things called best practice alerts. So if I want to do a guideline finding out if I order a certain test on a child with a certain problem, sometimes it can work out that when that diagnosis, when the electronic medical record knows I'm seeing a patient with that diagnosis, it pops something out on the screen in front of me to remind me to order that test. So that's a way to make the guidelines very simple and accessible to use. Does it fit into my workflow, or do I have to completely change my workflow? Sometimes you have to change, but it has to be well worth it. And is the guideline, once again, readily available? Is it something that I can find easily, for example, on the web? There's external factors that interfere with implementation of evidence-based practices. So for example, there's the organizational constraints. Does the organization have SOPs, standard operating procedures, especially for staff? If you want staff to gather certain information or do certain tests like blood pressure when a patient is coming into the clinic, do you have training that gives everybody a certain specific way of doing these things? Are there certain constraints at the care setting? Is there enough space, or are there too many patients coming through? And is there a link to quality management? Quality management is an important part of any practice, in fact, in any field at all. Is this guideline going to help people work in the quality area where they can see easily they're improving their quality? Is there a lack of resources like money, time, personnel, space? And is there a lack of collaboration? Does the guideline call for multidisciplinary care? Again, going back to my cerebral palsy example, spasticity management, cerebral palsy. You need the rehab doctor, you need the orthopedist, you need the neurosurgeon, you need the physical therapist, you need a lot of different specialists. Are people willing to work together in one form or another to give multidisciplinary care, or is your culture one of silos? So some of the strategies for external factors, including developing standard operating procedures and tying the use of those operating procedures to expectations, and then constantly evaluating outcomes. And we'll talk about that more in a few minutes. Then define the resources, clarify the roles of the personnel. People will sometimes say, that's not my job. Well, leaders sometimes have to come in and say, this is best practice for these patients. So this now is your job. Finding the space, the equipment, and the finance, and the time. Time is part of the financial investment. Time is money, and time is people's time is for it's paid for. So that's part of the financial investment. And then there's the idea of building a culture of collaboration and innovation. The way you build a culture is by setting expectations and then rewarding certain behaviors. There's some social and clinical norms that are barriers to implementation. And you'll notice that I don't have a strategy slide for this one because these are harder. So for example, there's financial barriers. And the example I'm giving over here is the prostate-specific antigen, the prostate test for prostate cancer that is done for men of a certain age. There was a lot that came out in the past several years that said that this test should not be done for men over 70 because it doesn't make a difference. In many urology practices, up to 25 to 30% of their practice was following up on the negative results of these tests. So when people started to say we shouldn't follow up on it anymore, that would cut their income 25%. So that was a very difficult idea to put forward. And then there's accepted norms. There was a time that came out that said that mammograms should only start for women at 50. The guidelines talk about 40, but people said, the ones who did the evidence-based studies said it should wait until 50. Well, that caused a tremendous uproar, and many, many case examples of women who had breast cancer that was detected by mammograms before age 50, even though with the evidence base and the testing, these anecdotal stories didn't really justify doing all of the tests that were done. Nevertheless, it created such a stir that we're still doing it at the younger age. And then there's group beliefs. Certain religious beliefs about certain practices may interfere with the implementation of new evidence-based practices. And then beyond religion, just cultural beliefs. There have always been interesting beliefs about individuals with disabilities. In some cultures, individuals with disabilities were shunted aside, closeted. And the idea of doing major interventions to help bring them out to be more independent and increase their quality of life was something that was just not accepted in the society. Vaccinations is another example I don't have to talk about too much. It's been in all the papers and everybody knows about how there's certain cultural beliefs about vaccinations that are interfering with people getting vaccinated today. As far as the political one, well, that's something else I don't have to talk about. I can either just skip it or we can talk about it for 2 or 3 hours. How things like infectious disease used to be medical and scientifically based, and now it's purely political what you think about certain infectious diseases. It's an interesting phenomenon. Then there's just societal practices that are too hard to give up. There have been studies that suggest that using cell phones can cause brain cancer. I'm not telling you those studies are accurate. I don't know. I haven't seen much about those studies. But no matter how many studies you published, people weren't going to give up cell phones. Same example for smoking. All these years, we haven't been able to get rid of smoking, even though we inform people over and over again that smoking is the #1 preventable risk factor for heart disease and other forms of mortality. I've heard that smoking lately is on the rise in young people, which is unbelievable. So there's certain things that interfere with these things interfere with evidence-based practices coming into our society as things that we practice as the norm, and these things are much more difficult to get around. Let's talk about knowledge translation. There's several terms that refer to knowledge translation, like dissemination, diffusion, knowledge transfer, knowledge utilization, research utilization, knowledge translation, and we've been talking about implementation science, which it's not all about knowledge translations, like I said, but that plays a big part of it. This is the cycle of knowledge translation. In the middle of the cycle, there's the knowledge creation. It starts off with a question, knowledge inquiry, and then knowledge is synthesized. Studies are done, research are done, experiments are done, and knowledge is produced. And then that knowledge is turned into tools like publications or guidelines or things like that that become tools that can be used. Now, if we go down to the bottom of the circle, we see that we have, let's take a clinical situation where a problem is identified. So how do we solve that problem? Well, the first thing we do is we identify, review, and select the knowledge which was created. And then you take that knowledge and you apply it to your local context. So if there's a knowledge about a certain screening procedure for a certain medical problem, how can you best do that within your clinic setup? How would that best work? And then once you've done that, you look at the barriers that we've talked about to knowledge use. Do you have the personnel? Do you have the finances? Do people believe it's going to work? Who do you have to convince? All of the things that we discussed. And once you do that, you select the intervention you're going to do, you tailor it to your clinic, and then you implement that intervention. Once you implement it, you monitor what happened. You look at outcomes, you look at how the knowledge is used, and you evaluate, evaluate the outcomes. And with that, you sustain the knowledge use by looking at those outcomes and then working with what new problems come up to make those outcomes better. And that takes us back to the bottom of the circle where we've identified problems and we start over again, trying to solve the new problems that come up once we put a new evidence-based practice into practice. So one of the ways that this is done, one of the methodologies for this is what's called a learning health system. So what is a learning health system? A learning health system is where information is generated from patients within a system that's continuously analyzing that information to improve patient care. This means that as we see patients in clinic, we gather the information about them, we put it into the medical record in such a way that we can pull that information out and how can we improve them. In this, research and clinicians analyze various types of health information, including data from clinical visits, laboratory results, medical imaging, genetic profiling, and we use that data to gain an understanding of the disease process and how medical interventions affect disease outcomes. The ultimate goal is to use these analyses to make tailored patient care decisions. What we tend to do without a learning health system is we decide we want to study a problem. We assemble all the relevant data, we analyze the data, we interpret the results, and then what do? We write a paper, we send it off to journals. Well, I can tell you too many examples where people have written a paper saying that such and such should be practiced, but it's not being practiced in their own clinic because of all the implementation barriers that we talked about. Well, in a learning health system, we get in there and we get up to that point where we talk about interpreting the results. And then we take it back to the group that's doing the clinical practice and we delivered a tailored message to them and we take action to change practice. Again, it goes around into that circle. Once we take action to change practice, we decide we're going to study the action that we just took and we take it around back in a circle to improve outcomes. That's what a learning health system does. So the outcome of learning health system is a quality assurance and quality improvement to evaluate safety and outcomes and eventually improve them. It also improves training opportunities, giving trainees evidence-based information on interventions, not just someone's opinion. I'm sure many of you have had the experience of working with different senior people in your field, different people that were involved in your training. And as you move from one setting to another, you got different information about the same situation. We all are our own experts, but we don't always have the information we need to really know what that expertise is. That's what the learning health system tries to change. And then with that, we want to tell everybody. We want to publish and tell everybody about it. So we have the production of outcomes research, sharing the knowledge at international levels, but then on the more local level, we can give this information to a patient. We can give them detailed information based on our experience to make good intervention choices. So if I want to perform a surgery on a patient, I don't do surgery, I do some injections. So if I want to do an injection on a patient, I can say to them, our clinic experience is that when I see a patient who's about your age and has your medical problem presenting the way that you do, our chances of being successful with the procedure have been about 80%. So that way the patient can make an informed decision. All right, so the conclusions, it's critical to increase the evidence base in all fields of medicine, but the impact will not be felt without attention to knowledge transfer and implementation strategies. Implementation might be blocked by several factors, including factors related to the clinician, the intervention or guideline, and or the external environment. Increasing access to knowledge dissemination, including expert endorsement and skill-based learning, resource availability, and developing a culture of change and innovation are important strategies. Outcome evaluation, for example, through a learning health system, is a strong tool for fostering the implementation of evidence-based interventions. And that's it. That's all I wanted to talk to you as an introduction today. And before we move into our assignment and start talking about the various interventions, does anybody have any questions? Okay, hearing none, Michael, we can just move right into the assignments. That's okay?
Sure.
Okay, great, good. Okay, so I will call on you to talk to me about your assignments. So the first one I've pulled up here is Adam, Kaylee, and Kat, talking about selective dorsal rhizotomy and about cannabis for ASD. So let's start with that one. Who would like to speak first?
I can go. Let's see.
Okay.
Do you want me to share the screen for the write-up, or do you want me to?
No, just go ahead and talk it out. Yeah.
Okay. Well, I'll bring it up on my screen. So I'm going to start off with talking about the selective dorsal rhizotomy for cerebral palsy. Just a brief summary of what that is. SDR is a surgical procedure performed on the lower spinal cord. The nerves are separated, then identified via electrical stimulation. Identification, certain sensory nerve fibers in the spinal cord are cut. The nerves that are led to too much muscle tone, which is a condition of cerebral palsy and spasticity, are then cut. So rate the intervention based on your findings. The whole group, we each determined that there's some evidence, but not convincing. Kaylee said, I believe I would rate this intervention as yellow for the reason that there's research behind this intervention, but not evidence that it actually works and makes a positive impact. I determined it as yellow as well. The surgery has been done for actually many years, I think over 100, and obviously it's gone with gone many advances since. But there, from what I've been researching, there's some conflicting evidence about the long-term effectiveness of the procedure. It's not a suitable treatment for all children with CP that have spasticity. So I guess the resources we did is some professional journals, some academic journals. I guess what is the cost-benefit ratio for the intervention? Need for physical therapy for at least a year is quite extensive. So time and money, surgery expensive, and there's some complications post-surgery. Other medical conditions can occur during recovery. Some studies showed infections to wound sites, while others have hypersensitivity to other limbs. There could be pain management issues. The research I found said some don't know the long-term effects as patients, because usually the surgery is done for patients generally around the age of 3 to 10. So some studies say they don't know the long-term effects as the patient develops and transitions into adulthood. The results from SDR might be achieved through other interventions. Obviously, the main thing is the surgery is irreversible. Long-term effects of SDR with respect to spasticity reduction is unclear, with many studies reporting a high amount of add-on spasticity treatment is needed further down the line. Benefits. Benefits, obviously, improvement of gait, ability to sit. The biggest one why the surgery would be done is quality of life, improved in terms of functioning, participation, physical health, emotional well-being, self-esteem. Also could reduce pain. So I said it also improves mobility, reduces pain, relieves lower limb muscle spasticity. Obviously, the biggest one is the improvement of quality of life. Going back to rates of intervention based on the above, but considering some ethics, I put the family should be provided, obviously, of the pros and cons of SDR. They definitely need to be, they should meet with a multidisciplinary team to discuss SDR and the alternatives, because there are non-surgical alternatives. The benefits obviously must outweigh the risk, and parents should not be pressured into something they are not comfortable with. And the last question for SDR, for a taxpayer, would you recommend the funding of studies? And we all agreed that it should be researched further to determine the, yeah, like I say, it's been done pretty successfully, but definitely I think more research should be done.
Great, Adam. Great. So a couple of comments about this. There is an extensive literature, and of course, you know, in the context of the assignment, you guys did a pretty good job of pulling up several articles, and you pulled up some of the newer ones, and that's just great. The rhizotomy is a procedure we do commonly recommend in clinic. Whether it is controversial or not is controversial. That really depends on which clinic you're sitting in. The thing about doing more research for it is there is still a very broad view of, you know, who's the best candidate, how should that be determined, and what's the best technique. So even after 100 years, and in the more modern form, it's about 30 years, we're still arguing about it.
Yeah, that's one of the biggest things I saw was that even when I looked at the different clinics that were doing the procedure, or even the literature, one of the most clear-cut thing was they couldn't determine uniformly what the best candidate was. Like, so each place had their own criteria, but I guess every case is different too. So
yeah, but there's a little more controversy about things like the rhizotomy than, you know, than some others. So okay, great job. All right, Kaylee or Kat, do you want to talk about cannabis for ASD?
I can talk about, we have just kind of this little brief summary. Sorry, I have a dog that's jumping on me, so bear with me. Increased prevalence and decriminalization of cannabis for medical use in some states have led to more frequent questions for pediatricians about the use of cannabis for difficult to treat developmental and behavioral conditions associated with ASD. So for the first question, we have rate the intervention based on your findings. We all wrote, we all put yellow, so some evidence but not convincing. It's a new intervention with limited evidence. The one thing coming from an ABA fact is that there are studies that have been done to support, but among these, they don't have how to administer it appropriately to produce these desired results. And then there's also that misconception of, is this supposed to help? Or some people may be under the misconception of, does it cure ASD? There's that. And then another one is that a lot of misinformation is being presented as a miracle treatment by parent advocates. So then we have, what resources did you use to evaluate this intervention? We had two articles. Both Kaylee and I actually researched the same article. So that was kind of, we matched up a lot on our answers here. Cost of benefits. So what are some of the costs? There are adverse outcomes were also reported when using cannabis treatment, which includes severe psychosis, increased agitation, drowsiness, decrease in appetite, and irritability. Can also be costly, interact with different medications. I wrote, there's no definite instructions on how to implement it, of how much, what time of day, the potency, does age or weight play a factor? These can all become like very dangerous in administering to any individuals if we don't have the correct dosage. And then you have animals and wrote that is still illegal at a federal level, not enough research on how it affects a child's developing brain. For benefits, the one article did say there had been improvement for those who had epilepsy also along with ASD, and self-harm and dangerous behaviors. There have been some decreases in some individuals, but it's not across the board. Another one was ABA services can be very expensive. Not everyone can afford it, not every insurance. So from a parent aspect perspective, if they feel like they don't have accessibility to some type of treatment, for them, this may feel that they have some type of control in getting care for their child. So then if we go back and rate the intervention again, we all agree that we have yellow here. I would not recommend until more research is completed in this area, but cannabis can be shown to help in different scenarios. Is from what Kaylee said. I, as an ABA therapist, one thing is I don't want to come off judgmental and I want to be open-minded. So I would encourage to do additional research with them, do it together. So that will help. We could talk about what evidence-based practice is and what qualifies a good practice for treatment for ASD. And then we have remembering you're a taxpayer. Would you recommend funding studies that study efficiency of this intervention? We all wrote green on this, especially soon with how big cannabis world is becoming. Could be dangerous to people with ASD. Again, I'm going back to the instructions. How do you administer it? That's not very clear. And then further research has been given approval to determine if cannabis can and be used for this treatment. So.
Great, Kat, thanks. So I think the most interesting thing about thinking about cannabis for anything, but certainly for ASD, is if you think about the list of barriers that we talked about. So there's the attitudinal barrier. People have different attitudes about cannabis. It may depend on how gray your hair is in terms of cannabis and legal cannabis thing, and that may really affect your ability to absorb the idea that cannabis could be helpful for certain medical conditions. On the other hand, it may interfere with your ability to think that there's anything wrong with using cannabis. Cannabis is a wonder drug. There's nothing wrong with cannabis. I used it all the time in college and it never hurt me, right? So, I did not. But so your attitude about cannabis may really affect things. There's the politics we talked about. There's some real difficulties in doing research into cannabis because there's certain barriers in doing research into cannabis because it's not legal on the federal level. So there's many interesting, and then there is the societal issue of, this is something we'll see with a lot of these interventions. Kat, you mentioned that the research you did was with published articles. That's great. There's a lot more information about this just on the web, right?
Yep.
Not necessarily good information, but it's the information that's out there that most people are looking at. And that's all just positive and there's no problems. Or then there's the other side of it, which this is just deadly drug that's going to kill. So, all those things come into play. Okay, good job. All right, I'm going to call on Madison. Madison, I don't think Ada is here. So Madison, why don't you quickly run through what you two studied, including acupuncture for developmental delays. And I'm going to encourage everybody to kind of summarize a little bit so we can get through everybody's.
Great, thank you. For acupuncture for developmental delays, we initially rated this intervention a red, and we used an article published in 2011 reviewing it. And they found that of the studies reviewed, the majority had faulty research designs. The researchers were unable to be verified as unbiased, and the studies were not randomized, and the control groups were receiving behavioral interventions. The outcomes were measured subjectively. And so if we go to the cost-benefit ratio, risks are that acupuncture is expensive and it's unlikely to be covered by insurance, and it may or may not help anything. Additionally, it can be hard to find in rural areas, may take up time that could have been used for other alternative treatments that are more backed by evidence, and that the child may not be able to sit for a treatment, and there's a lot of needles, so that may be a turnoff for those who have fears of them. And it could be potentially problematic or dangerous. And if you compare that to the benefits, it may aid in relaxation and may help to align with family, spiritual, or cultural beliefs. So to rate the intervention again, considering the ethics, we did a yellow. We would not actively recommend it or perform it in treatments. However, we would not necessarily discourage patients from seeking it outside of our clinics if they make their own decisions and determine that it is a reputable treatment center and they are willing to consider the risks. As a taxpayer, we continue to rate this a yellow, and that we would prefer our money to go elsewhere in researching alternative treatments that have more of a reliable positive outcomes.
Great, Madison. So acupuncture is a great example of what I talked about in the ethics chapter in terms of, you have to show a little humility here where, I agree with everything you said, Madison, right down the line, and I might have been a little redder than you in some of these things. But the truth is, acupuncture has been used by millions, if not billions of people for thousands and thousands and thousands of years. And I always say, the fact that I can't get a p-value to work on it, I don't know if that's against all of that experience. Does all that experience, is that worth nothing because I can't do any good evidence-based studies? I'm not sure. It is possible for people to fool themselves even by the millions. But, so acupuncture is part of a very strong part of culture of billions of people in this world. And so that's why it definitely gets a yellow for the ethics and child health part, where you say, maybe I wouldn't recommend it, but I certainly wouldn't tell you not to do it, because that's where that humility comes in about some of these methods. Research in acupuncture is extremely, extremely hard. There's some very interesting tries to do randomized controlled trials, but what's the placebo effect? I've seen studies, and I hope this doesn't sound offensive. Chinese men who knew nothing about acupuncture just randomly sticking needles into people. Like seriously, that's a study. I mean, so it's a challenging thing to study, but a challenging thing to say no to when you look at the world experience. Why don't you tell us a little bit about exercise and strengthening in cerebral palsy?
Yeah, for exercise and strengthening for cerebral palsy, we rated it all greens in the categories of initial ratings, ethics, and taxpayer funding research for intervention. We used a meta-analysis of multiple RCTs that was written in 2014, and it did say that there was ample research in support of the effectiveness of this treatment. However, some of the individual studies were not sufficient to make a definitive conclusion that it was effective. However, there was a lot of research to support that it could be positive. In the considerations of cost to benefit, we found that strengthening and electrical stimulation interventions could increase muscle strength. It could increase the ability and endurance during walking, improve their gait, performance in activities, engagement in other activities. Some of the risks would be a waste of time if it is ineffective. There was some a little bit of controversy of whether or not it could actually make spasticity worse. So that is a potential risk. However, it did say that there was low risk of injury, and that's usually if it's not performed properly, so safety protocols should be followed. So that's why we would recommend it ethically, and there should be more research needed. There isn't enough to definitively say that it is effective, and I think that with more research and understanding, it could be helpful.
Appreciate that, Madison, because that's one of the things my group does research in. So I appreciate your support. This exercise and strengthening cerebral palsy is a great example of where implementation science and implementation barriers, the barriers fell. So there was a strong feeling among many that doing strengthening cerebral palsy was a bad idea, because if you take a muscle that's spastic and tight and make it stronger, won't it just be more spastic? And also, if you can't control your muscles very well, can you really get stronger? And so there was some good research that actually showed that you don't get more spastic, you do get stronger. And then there was tremendous endorsement from some of the top people in the field with some important editorials and important journals that said that we must start doing this. This is important for people with cerebral palsy. And barriers fell. And so now strengthening and exercise in cerebral palsy is a very popular way to help people with cerebral palsy. Great, good work, Madison. And regards to your partner on that one, so when she sees the video. Okay, let's call on Allison, Crystal, and Ashley to talk about Ritalin for ADHD.
I'll go ahead and get started. So essentially we gave it a green rating, and we talked through a lot of different things, but one thing we wanted to mention is that it's considered standard practice. So Crystal is a DBP, which is super helpful. So she was able to tell us that it's written into the clinical practice guideline for all pediatricians for management of ADHD. And then we also looked in the literature. So we found some RCTs that talked about the effectiveness and showed that it was effective, and then also some different meta-analyses regarding the use of Ritalin, which again supported the use of Ritalin for managing ADHD symptoms. In terms of costs and benefits, we talked about a risk of lots of different types of adverse effects. So essentially things like headaches, stomach aches, tics, irritability, appetite suppression, all those kinds of side effects that you may see, and also some side effects that maybe long-term use of a stimulant medication could have. So things related to like height, for example. In terms of benefits, we talked about it likely being covered by insurance. I know like just based on kind of a quick search, I saw that some insurance is better about covering it than others, and there still may be some kind of copay that could essentially be a cost as well, a large cost for some families, but typically there is some coverage by insurance, which is good. Also thinking about it having a pretty immediate effect, and it not really interfering with usual care beyond like contraindications with other medications potentially. We also talked about psychosocial benefits. So essentially helping them be able to like inhibit impulses. Maybe that'll lead to some better interactions with peers and parents and teachers and those types of individuals. And also the flexibility of Ritalin or stimulant medication in terms of it being able to be started or stopped without really serious consequences like we may see from other medications. So essentially based on all of that in the chapter, we gave Ritalin for ADHD a green rating, meaning we would recommend it to families. In terms of funding though, we actually gave it a yellow recommendation just because it seems like there is a lot of evidence out there already for it, talking about like benefits or again, potential risks and such. So it's not maybe as high of a priority as other like areas or therapies or medications and things that could be effective that we don't have as much medication about. So that was our spiel for Ritalin.
Yeah, Allison, no, I think you really, it's interesting about the research. And that's one of the reasons I included this one. You're right. There's tremendous amount of research, tremendous amount of practice. Do we really need to do more research? Well, the answer is that for any intervention you do with people, there's always more research questions. But, if you're the NIH and you're trying to decide about a new genetic cancer treatment versus a Ritalin study, how do you, well, we know Ritalin works. You want to fine tune it a little bit more. How much we spend? It still needs to do research on it. But, in terms of priorities, it's kind of an interesting question. The other interesting question about this is you gave the solid greens for evidence-based and all that kind of thing. But how many parents will say, I don't want to put my kid on a medication? I'm afraid of medications, that kind of thing. You have parents say sometimes, I don't want my child to be dependent on medication. And what I like to say sometimes when I'm in that kind of mood is, your child is already dependent on the medication, they're just not getting it. So that's what makes Ritalin kind of interesting. Janie put a question in. Did you think about the counter effects on kids? Janie, you're talking about like the negative effects, some of the negative side effects. So that certainly is something that has to be considered. Kids lose appetite, they have growth issues and that kind of thing. So those are all things that need to be considered when you make the clinical decision, and all that's in the guidelines about how to monitor. So it's never open and shut, but it is something that's very well accepted. I hear. Janie points out that her child had horrible experience with ADHD meds. I actually also have a child with neurodevelopmental disability that we had to take her off the meds because of her reaction to them. So there are always issues, and there's ways, and the research can reach out to start to think about ways to improve the care. So that's a good point. Okay, someone else on the team talking about hippotherapy for cerebral palsy, either Crystal or Ashley.
Yeah, so I'll talk about that. So for anybody who doesn't know what it is, because I didn't at first, hippotherapy for cerebral palsy is when they go with horses and use equine equipment to help strengthen their muscles. So we actually, after looking at this, we actually gave it a green rating. There is quite a few randomized controlled trial studies on it that are more recent. A lot of the research is a more recent research versus over a long period of time for it. So because of that, we decided to go with green with the randomized control style trials. And then we also found a review article that had some concerns with quality of it, but it seemed like it was something that had decent research behind it. Looking at the costs and benefits of it, one of the big costs that we noted was the high cost of the treatment, because you have to be able to afford the equipment for the horses, a location for it. You have to have the proper people on staff to make sure that the treatment is going appropriately. And a lot of that, it might not be covered by their insurance. So that's going to be a high cost put directly on those families themselves. We also were talking about how you need to make sure that the correct staff are there. It can't just be somebody who has a horse ranch and is also passionate about neurodevelopmental disabilities, and then calling that therapy. Based on time and cost with it, it could also potentially affect their other treatments that they have, their other care for their cerebral palsy. Based on location, they might not have a lot of them near them. So it might be a lot of travel time that they have to do, which is, if it's 30 minutes away, back. So if they're also doing physical therapy or occupational therapy and other things like that, it could be too many things for the family to be able to manage. So it might just have too much time to it. Benefit wise, there's a lot of social benefits for the child bonding with the horse. There is a lot of benefit also with them bonding as a family, doing the activity together. They could turn it into like a family experience. On Saturdays we go and do this. So they're doing therapy, but family bonding at the same time. It does help with muscle strength and control. And there's little adverse effects to it just because it's not like they're on a medication or doing anything like that. They're just out riding on a horse. So looking at all of that, we decided to rate it again. We kind of gave it a yellow just because we were thinking that there's not anything wrong with the therapy, but it wouldn't necessarily be something where every family with a child with CP comes in the door and we would recommend this therapy to them. We'd be like, oh, here's this great thing that we think that, could be there. We didn't feel that that was going to be what we felt with it. A lot of times that people are going to recommend PT over a therapy like this. But we didn't feel that it was a negative approach where we would, if a family brought it to us, that we would deter them away from that kind of a treatment. So overall, in the end, we decided to, looking at taxpayer money, we decided to give that also a yellow. We feel that there is a lot of newer research out there that are good research studies that were completed, but we still feel like there is more to determine if it's equally effective with PT or if it's not, or if it should be something that is only complementary, or if it's a separate option for families if they, for whatever reason, don't want to do PT. So we definitely don't think it's a waste of time to do more research on it, but we don't think it's something that needs to be done right now.
Great, Ashley. That's really great. So let me make this comment about hippotherapy. I love hippotherapy. I don't believe the hippotherapy does many of the things that the people say that it does. But let me say this. We sometimes have people exercise on a ball. We sometimes have people exercise on a treadmill. You can also exercise on a horse. I don't know if any of you are equestrians. I have equestrian friends, and they tell me that after a good workout, they sweat. That kind of thing. It's a lot of work, physical work riding a horse. So it's great exercise, and it works on trunk control, which is a great thing. But the most important thing is that it's fun, it's motivating, it's engaging, it's participatory. It beats the living heck out of sitting in a gym and getting your muscles stretched. So it's just been a wonderful experience. And if you talk to kids, as they grow up, they'll remember that as something positive in their life, as opposed to just going to the PT gym. So that makes it great. And it's always good to do more research on things. But if you research on the exact benefits or this kind of thing, I don't know. It's not going to change my mind about ordering it, and it's not going to change families' minds. The one thing I definitely would say about it, this is not the kind of therapy that you would ever say, you must do this hippotherapy for your own good. If the kid don't want to ride a horse, then do something else the kid would find fun, right? That's the basic idea. Get the kid moving, get the kid stronger, get the kid active, get the neurologic system working. And if a horse can do it, it's the greatest thing. So more research, yeah, everything can use more research, but a lot of money in it? No, not really. So great. Thanks, Ashley. Let me call on Callie and Nicole. I believe is for social skills training. Who would like to talk about that?
I can talk about social skills training.
The social skills training in ASD, I should say. Yeah, go ahead.
Specifically in ASD. So we rated this intervention as green, evidence-based practice. And so there is good evidence supporting that this has an effect, although the effect size does tend to be small to moderate and based primarily on unblinded parent-rated social skills. And so the information that we use to evaluate this intervention. So I started off with a PubMed search of that, and I came up and I looked primarily for randomized controlled trials and meta-analysis or systematic reviews and more recent ones. And so I came up with several of those that supported that, as well as then I did just kind of a quick Google search, and the National Professional Development Center on Autism Spectrum Disorder does consider this 27 evidence-based practices supporting autism. And so that was kind of where I came up with my assessment of social skills. And so some kind of potential costs associated with this. And so this is really just kind of directed group play in many cases, or working on specific social skills that can be applied in broad contexts in the older kids. And so some potential costs would be potential missed school time if this is going to interfere with that, depending on when and where that's implemented. There were some studies that pointed that there may be instances where there's some social withdrawal and depression just due to increased awareness of one's challenges for kids with autism, and then just some feeling uncomfortable or annoyed with other group members, and then some other rare reports of increased stress, anxiety, fatigue, behavioral problems, or decreased attention. And then another large cost would be the time and money needed to train professionals to deliver that program. However, the benefits are improvement primarily in parent-rated social communication skills. They don't tend to translate into teacher-rated improvements. And it seemed like overall the benefits kind of outweighed those costs, because it seemed like many of those costs were things that could be mitigated in various ways easily. And then kind of going back and reviewing the intervention from an ethics perspective, I would still rate this as a green. Most studies compare this similarly to standard treatment or on an intention to treat or a wait list type thing. So there's really little harm to those who aren't receiving that treatment. And then in terms of taxpayer funding additional studies, so I would recommend, I put this as kind of a green, but I was green, yellow kind of on it. I would recommend further studies focusing more on particular groups, particularly females with autism, some longer durations of the social skills group training, and then trying to have some more blinded ratings by parent if possible, or other ways of assessing that are a little bit more objective, as well as some studies focusing on individuals with comorbid intellectual disabilities, which are primarily excluded just due to the difficulty of teaching those skills. And then also, so just kind of fine tuning the best way to implement this program.
Great. Good job, Nicole. So one of the things to think about when you think about, should we be investing more in this, doing more research in it, that kind of thing, is how important is the problem? So how important is ASD? Well, we can all make our own judgments. I will tell you, it is so extremely common and so extremely prevalent that it's very important. And we know that if it comes out all green here, as far as, is it evidence-based and that kind of thing, we could really be making a difference for a lot of people. So, when you think about that, that's very important. But what's the problem with this intervention? The problem with this intervention is there's not a pill. We need a pill for social skills. This intervention is costly. It takes a lot of people. People cost money. It takes a lot of time. You really have to be in a place that has the resources, that kind of thing. And it can really help a lot of people, but it's very hard to, get it paid for. Even if it's evidence-based, it's hard to get it paid for because it's very expensive, because it's a lot of people, a lot of time. So that's a big barrier for implementation here. So I think you're right on the mark when you talk about how best to apply this intervention. We're starting to do some work now with the idea of how much of this can you do on your own without much professional input with web-based interventions, putting this on the family, which is already overburdened. And I'm not suggesting we just take it and put it on the family. I suggest that we put resources into this, but where resources aren't available, can we do this effectively at all with less resources? Great area for research in a place that's going to be very high impact. So that's something to think about in terms of implementation. How high is the impact? That makes it important to do. How difficult is the intervention? That's a barrier. So great. Callie, do you want to talk about robotic or locomat therapy for cerebral palsy?
Yeah, of course. So robotic and locomat therapy for cerebral palsy, for those who don't know, is a robotic exoskeleton. So a child or adult is strapped into a harness, placed on a treadmill, and then strapped to the skeleton of the it's used for strengthening at times and normal gait. So we rated this as a yellow. There's some evidence out there. It's not super convincing. There were not a lot of randomized controlled trials, and studies within this population were fewer than some other populations, such as TBI patients, stroke, things like that. So we looked at some PubMed articles, and then also went to Locomat's website just to kind of see what they had to say and what research was out there, and compared the two. Overall, We're cautious with the quality of the information. Like I said, there's not much data on the specific population or the strong benefits for the specific population that is statistically significant. Some costs is that it's a very expensive and it can be time intensive for both the cost of the equipment and the time. The availability of services, not every medical office or hospital is going to have access to this therapy. And then there is potential for limited benefit depending on the client and the type of cerebral palsy they have. Some benefits may be potential improvements in walking speed. There were some parental reports of fewer falls among their kids, and occasional trials or studies did have some other statistically significant findings depending on the study. So if we were to go back and look at this with the ethics and child health, we'd also rate it as yellow, probably not recommend it, but would not discourage it. There's not strong evidence for improvements in ambulation using robotic therapy, but it may provide some improvements for specific clients in things such as walking speed or other areas. So the costs do not outweigh the benefits, but there's also maybe a placebo effect for some patients as well. And then remembering that we are a taxpayer, would we recommend this? Similar to Nicole, kind of a yellow to green. There's not a lot of data out there. And a lot of the data talks about the efficacy in walking speed, but there's not as much research on kinesthetic patterns, muscle strength, or flexion. And there may be needing to look at some reasons to implement this in terms of intensity of treatment, how it works with concurrent therapies and procedures, and generalizability for these patients.
Well, thanks, Kelly. That's a great summary. And, when we went out as a medical center and spent over $1 million buying 2 of these things, the Zocamats, we were surely hoping that there would eventually be better results coming out of them, but we've been a little bit disappointed. The families love them, so it's one of those things where the families and the patients are way ahead of the research in terms of the outcomes, and they'll tell you they're getting great results, but in terms of actually documenting that or even seeing it, it's been a little hard and somewhat disappointing. Certainly doing something repetitively can improve the performance. I wonder if the upper extremity stuff where you're actually physically doing something with the hand as opposed to the Locomat where the machine is kind of guiding your walking is the upper extremity might be better, but for the walking thing, I have families that just love it, but we're just not seeing everything we'd like out of it despite spending all that money on it. So this is an implementation thing where the implementation got ahead of the evidence base, which can be very difficult sometimes from the professional point of view, but that's what we have. So thanks. All right, I'm going to call on Amelia and Heather. So could one of you talk about early intervention programs for Trisomy 21?
So I can talk about that. When we were researching this, the first thing we found is just a lot of research. One of the interesting things that came up was when you type in early intervention, that term shows up for so many different fields. So we had a hard, or at least I had a hard time narrowing it down to one specific field because there was early intervention in speech, early intervention in OT, in education, things like that. So it was really interesting. But overall, we did rate that green. We rated early intervention for Trisomy 21 in general green. We used PubMed, and then I also used my university's library. When we were doing our research into this, we did limit the search to papers written before 2000 or after 2000 in hopes of getting some more of the up-to-date research, as well as excluding some terminology that is not done anymore. And then also we only used papers that were free downloads in order to sort of mimic the parent experience of just going and searching for papers. When we did a cost benefit analysis of this, a lot of the cost will come from the time that's poured into these interventions, missed work, and things like that, transportation, and then also the cost of services. You know, if you're in early intervention or if you're in multiple interventions, it can get quite pricey. But you know, the benefits the benefits were great across a lot of different fields. A lot of them, you know, I saw some parent testimonials, I saw some like hard data, so there was a lot of benefit. We went back and we said, yes, we would recommend this to families, so it is green. And then when it comes to research as a taxpayer, we rated this yellow with the caveat that even though there is so much research right now, it is definitely warranted to go back every once in a while and do more research, just check up on things and make sure things are all still where they need to be. So not fully abandon it, but also it doesn't need copious amounts of research at this exact moment in time.
Great, Amelia. Thank you. That's a great summary. This goes back to some of the things I said before about being a very green intervention, but being very intensive in the amount of people that are needed. But one of the things that's very different with this intervention is that this intervention has been very successful in terms of in the political sphere, which means that, you know, we have done a great job as a society of convincing ourselves that we should really pay for this intervention. And that's why there is so much early intervention programming that's available now for kids of all diagnoses, including trisomy 21. So that's where advocacy was helpful. Because, you know, as much as we think early intervention is something that's always been there, I'm sure there was a time when people just thought it was a dumb, expensive idea, but now we've really seen the value. Is there room for more research? Well, some of the research that's going on in early intervention is taking that intervention back into the first year of life and seeing what can be done to help kids and how that changes outcomes. There'll probably also be room for intervention, for research here to constantly convince people that this is a good idea to spend money on. But I agree with you that we do have a lot of information and we may want to prioritize other things. So good summary. Okay. So that was Amelia. So Heather, do you want to talk about homeopathy?
Yes, so I looked for evidence to support the use of homeopathic medicine and looked at a few different sources. And for the first item, rate the intervention, I said red, which there's no evidence to support the practice. Empirical studies investigating the efficacy indicate that the treatment may be ineffective, so may have no impact on the aspect of ASD. One source suggested that homeopathy has been around for 300 years, and if there was evidence, the scientists would have found it by now. And in the last module, we talked a lot about empirical evidence, meaning that it could be replicated. There has to be observations and data that indicate that it is evidence-based and it does impact the individual in a positive way. I searched for peer-reviewed research through my university's library. I did find one journal article that was a systematic review it was from India, indicating that there's some evidence, but most of the evidence, when I dug deeper into that systematic review, it was more case studies and with small sample sizes and just unverified testimonials within that review. For the cost benefit ratio, I looked at the cost. Homeopathic medication can be costly, which in the end, it could not provide benefits. So parents are putting money into this approach, but may not be any benefits to the use of the products. There could be a risk of adverse effects. So thinking about the FDA does not regulate homeopathic medicine or homeopathy. Is seeking the use of an alternative medicine that may cause a risk. So consultation with a doctor is recommended. Maybe the benefits, looking at anecdotal evidence, There may be some benefit to the use of the homeopathy for the individual. There may be a role in strengthening family motivation and engagement through the use. So we look at that placebo effect again, and if there is that effect, we could think about, well, if they're using this particular treatment in conjunction with a medical treatment and it's encouraging engagement or it's encouraging motivation, then it may have some benefit. Going back and using ethics to rate the intervention again, I was between a yellow and a red on this one. Yellow in the aspect that with the doctor's recommendation and support, maybe a homeopathic treatment could provide benefit for some individuals. I'd be open-minded to work with the family to investigate the homeopathic aspect, hopefully helping them to see the benefits of interventions with a stronger scientific basis. And then I was red because as a speech pathologist, I can't, it's not within my scope of practice to recommend this type of intervention. And then harm, the cost aspect that I talked about earlier may be costly and that with no true benefit in the end. And then parents might consider putting off other treatments because they think that if they focus on this homeopathy, it could improve their child in terms of their overall goals. And then be remembering that I'm a taxpayer and recommending the funding of the studies. I was red at first, but then when I was listening to your presentation today, I went towards yellow just because maybe within a clinic, if a certain type of medication or a certain approach is working with a group of individuals and you can show across time with a certain population, maybe it could show it success. And we could say, yes, it's worked with 80% of our patients or our clients, and therefore the parents could make an informed decision. But at first I would not, when I was researching and looking through, I thought, no, I probably wouldn't recommend future research in this area. But that's all we have for that.
You know, interestingly enough, Heather, the very nice presentation. Thank you. Interestingly enough, one of the first comparative effectiveness studies with homeopathy, it's not a published study, but historically it was very effective. There was a terrible typhoid epidemic, I believe it was in England, and there was a homeopathic hospital and there was an allopathic hospital. And the allopathic hospital was doing things like giving people medicines that made them throw up and have diarrhea and it dehydrated them. And the homeopathic hospital was giving people homeopathic remedies, but also was giving them clean environment and good nutrition and good food. And guess which hospital had people dying in the hundreds, and the other hospital was doing very well. So homeopathy really caught on. Anyway, true story. So homeopathy, I wanted to, the thing I want to bring out about it is about that, how we talk to families about it. You really hit some of the points, Heather. If people have enough money, if it's not going to interfere with their care, and in fact, if you don't discourage the homeopathy, that will help the people to listen to you about doing the physical therapy or the social skills training and do your homeopathy at the same time, go right ahead. Then you can be supportive. But if people say, no, I don't want to give them this medicine that's going to help them, I'd rather give them the homeopathic medications, you have to try and work with them out of that. You know, will homeopathy ever hurt anybody? No, it's just water. It's just water. Will research ever show it does anything? No, it's just water. So it's a difficult issue to work through with families in terms of you don't want it to interfere with the aspects of care that we all know are going to be much better than just giving them a little bit of water. But the things that you talked about family involvement and placebo are also very important. So it can be very challenging working with these kinds of things. I feel differently about it than I do with acupuncture. As I say, acupuncture is in practice for thousands of years by billions of people. I don't know, but you have to keep that in mind. Homeopathy is just water. So I feel differently. All right, let me call on Emily, Sarah, and Angela to talk about vibration therapy for cerebral palsy. Who wants to go?
I'm going to go first and do that one. So vibration therapy for cerebral palsy, we thought that although studies exist that show improvement, we would give it a yellow. There's really no definitive answer of whether or not it truly improves certain symptoms. However, the results are pretty convincing, and we think that vibration therapy just needs to be done on a larger scale now that it more or less has been discovered to be safe. So a couple of resources that we used, one was a systematic review of literature and it integrated results from 28 previous studies done on vibration therapy. And it was in a peer-reviewed journal. And then the other one was a randomized controlled study over 6 months. So some of the costs that we found for vibration therapy is that it's short-term benefits. So it's something that will need to be done pretty frequently, and the results aren't shown to last for a long time. So its mechanism of action is also incompletely understood. So obviously it's more ideal to know exactly what is occurring to make these improvements. And then lastly, things like posture and bone mineral density were not shown to be affected, which I'm assuming it's ideal for those things to improve with these therapies in individuals with CP. However, there are several benefits that were discussed by these studies. It includes a positive effect on the ability to move, which is manifested in gross motor function, strength, gait, and mobility. The effects persist for up to 30 minutes after vibration therapy, but long-term effects manifest as reduced muscle tone and spasticity. So after we went back and read the ethics article, we went ahead and gave it a green as opposed to a yellow, just because it has really limited adverse effects, and it's been pretty widely practiced before. In terms of funding studies for vibration therapy, so originally we said green, just considering the symptoms that cerebral palsy can have on patients and that sort of thing. So we thought it would be worthwhile to fund research to look more into it and improve the quality of life of those affected. But I think that Ashley brought up a really good point in her presentation when she said that other things like PT that are really proven to help might be just more worthwhile looking into as opposed to this. But this does show some improvement, so who knows?
Yeah, who does? Emily, a good presentation. Vibration therapy is caught in that graph about the implementation. It sounds hokey. It sounds like something that shouldn't really work, but the studies seem to keep suggesting that it does work. But we in Michigan have not gone out and bought a vibration board. Someone just asked me about it the other day, in fact. And I'd like to dismiss it as something that, I don't know, but it keeps coming back and showing some good results. So it's caught in that, it's not well accepted. We don't talk about it a lot at the national meetings, but maybe it works. We're all still waiting to find out. So this is something that, again, an implementation, it's going to need more evidence, but it's going to be hard. It's hard to convince people to fund it because we don't feel strongly about, believing in it. So it's kind of caught. Okay, who's going to talk about ABA therapy for ASD?
I am. So ABA therapy for ASD, we rated it a green. ABA therapy has the most evidence for treating autism spectrum disorder. There is a ton of research on ABA therapy on the web, a ton of peer-reviewed journal articles describing the high level of evidence supporting ABA therapy for individuals with ASD. As far as the cost-benefit ratio, if insurance doesn't cover ABA therapy, it would cost a family about around $120 an hour, up to $4,800 a week. If a child was receiving just 20 hours of ABA therapy per week, it would cost a family around $124,000 per year. Benefits, as stated earlier, it's an evidence-based intervention to treat children with autism. It's highly effective in increasing language problem behaviors. We did rate this a green as recommending it to this intervention to families. And then the last, regarding the taxpayer and funding studies, I said green, but I think more studies should be done for best practice with the field growing and more clinics popping up and investors owning these clinics. The quality of care has declined with ABA therapy in some situations.
Yeah, so you feel standards need to be set.
Yes.
That's true. It's an effective intervention, but because it's not a pill, it's not a machine, it's very variable. So when you're getting ABA, you're really getting ABA. That's the question that has to come to mind. And I agree with you 100% about, are there ways that we could do more research to standardize it, and are there ways that we can keep charlatans out of the field, and and this kind of thing. But a very green intervention. And Michigan pays for ABA. Do you know why Michigan pays for ABA? Because we had a lieutenant governor who had a child with autism, and that's why Michigan pays for it.
Medicaid to get the autism coverage covered.
Yeah, that's because the lieutenant governor pushed the idea. So that's where politics comes into this as well. All right, Amelia Allen, that is. Amy is not able to make it. So Amelia, why don't you go ahead and tell us about chiropractic care for ASD?
Sure. So I wanted to start by reading what the chiropractic care for autism is intended for. So it says correcting the alignment of the spine reduces interference in the nervous system. After having their spine adjusted, many patients and their families have reported experiencing the patient is more relaxed and display more eye contact and increased willingness to be social. Some experts report that chiropractic care to have similar sensation and stress relief to stimming. However, the therapeutic effect of chiropractic care lasts for a much more prolonged period of time than self-care resulted in stimming. Also, it could maintain a healthy spinal alignment. Also, maintaining a healthy spinal alignment helps autistic children with their problems like digestive disorders, sleep disturbances, and bedwetting. So those are the claims. As far as what we would rate the intervention, both Amy and I rated it as a yellow. So in 2011, which was 11 years ago now, there was only 5 articles that talked about chiropractic care as it relates to supporting autism. And since then, there hasn't been much research to show that some of those claims, like the improving, like the neurological benefits, to it. So some evidence proves that it may improve the condition of children with autism, but not provide the full scope of care. So there was particularly research shows that there was benefits to children with things like toe walking and different physiological things that may come from autism, but not the neurological impacts of the condition. So as far as rating the intervention, I rated it a red and Amy rated it a yellow. More information is still needed, and I would not recommend it to a patient who was presenting with autism. So chiropractic care is a beneficial resource for all eligible individuals and who may experience adverse effects from misalignment. But the claims that it treats autism, I would say it doesn't. And the research does not support that it does either.
Okay. Great summary then, Amelia. And, there's just sometimes there's got to be physiology behind it, So we could argue about whether chiropractic helps misalignment, the back, that kind of thing. But I agree with you about autism. There just doesn't seem to be anything that they can produce physiologically that suggests that it's going to help. And that makes it very hard to recommend, very hard to support. It's costly and sometimes can take away from other treatments. You gave it a red, Amy gave it a yellow. in terms of recommending it, it's very hard to recommend. So, do you want to speak for Lance?
Sure. And that one is more straightforward. So cochlear implants for deafness. The cochlear implant is usually the intervention when other things haven't been successful for a patient, and they have the implant, and it can increase individuals' social skills and ability to learn language and express language, which overall, as a person develops, is extremely important. So we rated the intervention a green. And then as far as the considering ethics, I also rated it a green. Amy rated it a yellow. She spoke about the controversy within the deaf community, whether or not a non-hearing person should be changed, particularly since implants do not really provide full hearing. Also, if there was a level of hearing before the implant, now that's fully gone for that individual. And then as far as a recommendation for taxpayers, we both said yellow. It would be helpful to have more like longitudinal studies to see how cochlear implants over a lifespan of a person would be beneficial.
I think it's fascinating how, especially Amy brought out this idea about the cultural aspects of this, and how the deaf culture, the deaf world has found this to be a controversial intervention, when those of us who are not can't understand that. So this is where culture and implementation comes into play. As far as research, I think the thing we have to remember about cochlear implants is that if you ever seen a cochlear implant, it's kind of a little round thing sitting on the side of the head. There's wires. So I think that we'll look back at that in 25 years and we'll say, wow, look at those primitive cochlear implants. They'll look like a Model T Ford. And they'll have something that's like, the size of your fingernail that kind of fits behind your ear. That's your cochlear implant. So the research in that, there's still a good amount of research to do in terms of how we can, even just, that's just one aspect of the field of how we can make those things better. All right, well, that's taken us my clock says 6:58. And really, you guys really put your hearts and souls into this and really did a great job. And I think you hopefully brought out a lot of, learned a lot from this about, how we find out new information, some of the barriers to how we get it implemented, and then, how we finally think about, as a clinician, then as a taxpayer, how do we, how and when and why do we put these things into practice? So again, thanks everybody for their time, attention, and engagement in this assignment.
Thank you, Ed. I've always loved this one because I love to see hear everybody's point of view and the research that goes into these different interventions. Hippotherapy is still my favorite after 6 years. I love it. So yes, thank you all. Great job. Just one last reminder, there is a post-Zoom discussion board as part of Module 11, so don't forget to get in there this week and add your reflection about tonight and about the module. Evaluation, it's 7 o'clock, so evaluation was just emailed to you. So please, share your feedback about tonight's session and how we can make it better. Oh, hi! Hi, Crystal. It's okay, hi! So yeah, thank you all. Stay warm. If you have any questions about this module, about the session, please feel free to reach out to Dr. Hurwitz, or you can direct any questions my way, of course. So, another one. More kids. I love it.
and I'll be looking for everybody's assignment. There's that one other assignment to do, and I like to look at those, read them, and I'll make a few comments. So. Okay, very nice seeing everybody, meeting everybody, and everybody have a good night.
Have a great night, everybody. Take care. Thanks again, Ed. That was great.
Most welcome.